Hi.
Hi, everybody.
Hi, Cassandra.
Please, hi, Cassandra. Hey, Lexi.
Oh, hey, a quick question, Mr. Mike.
Go for it.
I took the dentition quiz. Would you still happen to still need to grade them?
Yeah, I haven't gotten to those yet.
Oh, no, copy that, because I was like, man, I think because it didn't match up, I got them wrong, but it's all right.
Yeah, I look over those. A lot of times those are, if there's credit, I'll give credit where it's due.
For sure. How you doing though, sir? It's been a while.
I know, a long time no see. You guys are all still alive? Everyone's doing well?
Yeah, yes, sir. All right, Lex, I'll let you go, right?
All right, I got a couple more minutes still. Wait for everyone to hop on. Everything going okay with the portfolio project?
I'm a little nervous, but I think I'll be good.
Right on. Just a quick presentation. Should be over pretty quick.
Did anyone watch the Cardinals game?
I did not. Nope.
You did not. It was a good game.
Was it a good game?
Yeah, it was.
I'm guessing they won, right?
Yeah, they won. And they got the what is it called? The wild card for
Okay.
the playoffs. So hopefully they keep winning.
Sweet. All right, is it just going to be you two today? All right, so I'm going to go ahead and get started. It's 5:30. I'm going to share my screen. Give me a second here. There it is. Okay, can you guys see that okay? Right on. All right, so we're talking about anesthesia and sedation in chapter 20 out of your Cengage textbook. I'm gonna go over a few things, some learning objectives that we'll talk about just for this chapter. So chapter 20 will describe some methods used to manage pain and anxiety associated with dental procedures. We'll explain various topical anesthetics and talk about some local anesthetics. We'll talk about the injection sites for the upper and lower teeth, and I'll explain where exactly those are and what they do. We'll describe what is needed to administer local anesthetic, as well as the steps taken to get that done. And then we'll discuss the role of nitrous oxide at the very end. All right, so let's get started. There we go. All right, so anesthetics and sedation are used to reduce pain. They can relieve anxiety. And then there's different levels of sedation that can be achieved based on the procedural need and the patient response. So many patients are very anxious about dental care and treatment, and sedation is one method of managing the anxiety of the patient. Anesthesia can also be used to control the pain a patient experiences, and depending on the need, there's different types of sedation that can be used. We'll go over all of those here in a second. So with conscious sedation, this places the patient in an altered sense or altered level of consciousness. So it doesn't completely knock them out, just kind of puts them like in a twilight sleep, I like to say. The patient is still able to communicate and respond to questions. And this form of sedation serves to lower the levels of pain and discomfort. And the patient may experience a headache, nausea, or periods of amnesia following conscious sedation, especially right after they wake up from it. With IV sedation, anesthetics are administered directly into the bloodstream and remain in place throughout the procedure. The patient may remain conscious, but is in a deeply relaxed state. The patient often has no recollection of the events that took place while under anesthetic, which is good. And this form of sedation keeps the patient relaxed, comfortable, and pain-free. So they have usually no recollection of what happened. They're completely asleep. They have no pain at all. With oral sedation, this is achieved by taking a medication the night before the dental procedure. This may be prescribed by a patient who is extremely anxious or extremely nervous about treatment or about the procedure that's going to be done. And things like benzodiazepines are often used and can be, they're used as a sedative hypnotic, which makes the patient calm and drowsy. And or anti-anxiety drugs can also be used, like Xanax, which makes the patient calm and relaxed. Inhalation sedation is used when it's difficult to achieve IV sedation. So this is when you have anesthetic that's administered in the form of a gas and is delivered through a mask. This will cause the patient to become sleepy and serves to relieve pain. This patient doesn't remember much of the procedure after it's done, and it's not long lasting, so the patient must be carefully monitored. Usually this is done in conjunction with IV sedation. So inhalation sedation will kind of just get them drowsy. It'll kind of knock them out into like a low level sleep until the IV sedation drugs start to work. We see this a lot in pediatric patients when it's difficult to get them to cooperate with any type of IV injections or anything like that. So we do this first, and then we'll do what we need to as far as IV injections to get them sedated completely. Intramuscular sedation is the injection that's injected directly into the muscle, usually the upper arm or the thigh. It's not commonly used, but again, in pediatric patients, it can be. It usually takes 20 to 30 minutes for it to take effect. And then there's 20 to 30 minutes to take effect just with this type of route of sedation. Again, this is intramuscular sedation. With general anesthesia, this creates an unconscious state or a deep level of sedation. The patient's vital signs must be closely monitored, and it's usually done by either anesthesiologist or an oral surgeon. And the patient will be on a ventilator for the duration of the sedation, so they have to be intubated for general anesthesia. General anesthesia alters and depresses the patient's central nervous system, and the patient will lose all feeling and all sensation while they're under GA. With topical anesthetics, there's just some examples of them in that picture to the right. This numbs a particular area, and it's usually done prior to local anesthetic, which is the injection. So we'll numb the area first with some type of topical anesthetic. The nerve endings in the mucosa are desensitized, which causes that numbness. And this alleviates the sensation of the pinch of the needle, so right before that local injection. All right, this is some example of what a local anesthesia looks like. Looks like we have some lidocaine there on the side there, some carbocaine that's in that can. Local anesthetics are used to reduce the sensation of pain, touch, and heat to a particular area. And this type of anesthetic works well to block nerve fibers that usually send messages back and forth from the brain to the sensory impulses. That's how that works there. And this produces a deadened or pain-free area. Again, the sensory impulses are temporarily blocked, so there's no sensation at all. And this affects the nerve fibers that carry messages to and fro to the brain and from the brain to the sensory nerves. All right, topical anesthetics. So these are used for subgingival scaling. They could be used for root planning. Also, when we're seating a crown, sometimes the patients are a little sensitive, but may not necessarily require an injection. So we'll use topical anesthetics for that sometimes. Also, when placing matrix bands, as you all are aware, sometimes those matrix bands can get, they're pretty close to the gum tissue, so that can be painful. Topical anesthetics can help with that. Periodontal probing can sometimes be painful for some patients that have sensitive gums. Preparing for local sedation or repressing a gag reflex. So with topical anesthetics, it's best to have the patients be cooperative, conscious, and relaxed for this. And topical anesthetics are available in gels, ointments, liquids, and sprays, which help prepare the area to accept the needle without pain. Usually it's done by something called a lidocaine or a benzocaine. And it can be sometimes, not a lot, but sometimes it can cause an allergic reaction with some patients. This can include redness, swelling, difficulty swallowing, sometimes difficulty breathing. Like if some of that anesthetic gets towards the back of their throat, it can freak patients out sometimes, especially if they're already anxious. A toxic reaction can also occur, and initially the patient will become more talkative, sometimes apprehensive or angry, and sometimes excited with an increase in pulse or blood pressure. Again, this is rare, but it's just some of the things that you have to kind of look for when placing topical anesthetic. So this is just a picture of somebody placing the topical anesthetic. First, you'll want to dry the tissue out with a piece of gauze. Place the topical anesthetic in the correct area, and then usually you want to put a piece of gauze on top of it and let it soak in the area. That gauze that we put on top of it is to keep the topical anesthetic from going all over their mouth. That's usually not a very comforting thing. So there's a picture of that there. Local anesthetics are used to manage pain. And they come in liquid form and are injected into the tissues. A short duration local will last approximately 30 minutes. Intermediate duration can last 60 minutes, or a long duration can be up to 90 minutes, and even longer with some of these newer local anesthetics. Local anesthetics also contain vasoconstrictors. These constrict blood vessels to reduce the blood flow around the surrounding tissues. And vasoconstrictors reduce the levels of anesthetics entering the bloodstream, reducing the chances of a toxic reaction, and decreases blood flow at the site. So this can be important because whenever we're working in the area, we want that whole field to be as clear as possible without any blood. So sometimes these local anesthetics can not only numb your patient, but prevent bleeding from happening in that area while you get the procedure done. Some possible complications of local anesthetics include toxic reactions. This is where the patient becomes ill, and there's many factors to this. It can include an overdose of anesthetic, or the type that's used, the absorption rate, or individual characteristics. For example, some of these anesthetics that we use, especially the ones that contain vasoconstrictors, have epinephrine in it. And epinephrine is a natural hormone that we make in our bodies. It's actually adrenaline, and that epinephrine is used as a vasoconstrictor. Sometimes that epinephrine can get into the bloodstream, and it can cause the person to be very shaky, or it can cause their heart rate to increase. So this is one of the toxic reactions that can happen. If this happens, if you happen to get epinephrine, or the doc, not you, if the doctor happens to get epinephrine into the patient's bloodstream and they have this type of racing heart type of sensation, it'll go away in a few minutes. It usually takes about 5 to 10 minutes for that sensation to go away. But a lot of times the patient will get freaked out. So you just have to kind of calm them down and reassure them that this feeling will go away. Another complication that we run into sometimes is paresthesia. This is numbness that does not go away as expected. Sometimes this happens if everybody's nerves in their face is kind of a little bit different. They should all be kind of the same, but sometimes people have different, the way their nerve endings isn't exactly how the doctor expected. And if they actually were to nick a nerve with a needle, this can cause some paresthesia. And a lot of the times the paresthesia goes away. Unfortunately, sometimes it can take a couple of months for that numbness to go away. And then there are some rare cases where we have paresthesia that does not go away at all. And so those are some of the things that these doctors need to be, or they are aware of, but that's usually for them to be aware of. But you should know what paresthesia is and what to expect if it does happen in your office. All right, so quick dental check here. Here we have a state of calmness, or the process of reducing nervous, or a state of calmness or the process of reducing nervous excitement is termed, or what is this called? Anybody know? Anybody help me out here?
Sedation? No.
Sedation. Good job. Thank you, Celise.
Oh, yeah.
So yeah, this is a state of calmness or the process of reducing nervous excitement. All right, so we're talking about types of injections now. And this is called the local infiltration. This is an injection that's near the small terminal end of the branches. You can see that terminal end is as opposed to the root end of those nerves. Local infiltration is used for various dental treatments, including root planing, soft tissue inclusions, for biopsies, gingivectomies, and frenectomies. The next, we have a field block, which is the injection near the large terminal nerve branches. So this is just one more branch up from the local infiltration. Again, that field block is right in the middle of those nerves. And this is usually given at the apex of the tooth and can involve 1 to 2 teeth. Usually the patient feels numb within 2 to 3 minutes after this type of injection. A nerve block is when we block that entire nerve. So this is usually done near the main trunk of the nerve. And nerve block injections are done to cover a larger area of teeth that need to be worked on. It is used to numb an entire region, and usually it takes effect within 5 minutes. So it takes a little bit longer than the other types of injections. Again, these are local infiltration was the first one that I went over. Field block is the second one. And of course, this one is a nerve block. Local infiltration covers 1 tooth. Field blocks cover up to 2 teeth, and nerve blocks can cover an entire quadrant. All right. So just looking over some of these injection sites. So this is the maxillary arch. Here we have, I can't really use my mouse here. You can't see my mouse. In that blue section there in the upper left, we have the middle superior alveolar nerve block. This injection is pretty much right where we see that X. It's right in that the buccal fold that's right in between the lip and the teeth. That is where that is at. And if you look on your book on page 453, there's a couple of tables. Table 20-1 talks about all these different sites, what they do, and exactly where the injection sites are. So for that middle superior alveolar nerve block, the injection site is going to be at the height of that mucal buccal fold at the maxillary second premolar. So right at where you see where that second premolar is, and that'll cover both of those premolars and that mesial aspect of that first molar. The posterior superior alveolar nerve block is right in that mucal buccal fold. That's right on the apex of that second molar. The nasal palatine nerve block is, if you remember where that palatine foramen is, it's right on the apex of those two central incisors. And that nerve injection will numb all of those teeth that are kind of highlighted in green. So if you ever need to do any anterior work, you want to block out all of those teeth, especially if we're working on veneers or something like that. That's exactly where that nerve or that injection should be. We'll caution this though, any type of injections that are done on the roof of the mouth or on the palate are going to be your more painful injections. So typically we don't like to give those injections unless we really have to. The ones that are done on the mucal buccal fold are a lot less painful, and all the pain can pretty much be taken away with topical anesthetics. That red section here where it says greater palatine nerve block, that numbs the hard palate and the soft tissue covering the hard palate from the distal of the canine and all those teeth posteriorly. So again, that is a nice one injection, knocks all these teeth out type of anesthetic, but it is on the roof of the mouth, which can be painful for your patient unless they're already numb there. And so that again numbs the hard palate and the soft tissues covering the hard palate from the distal of the canine and posteriorly. So moving on to the mandibular arch section, or the mandibular arch sites, we have that buccal nerve block in the blue there. With the buccal nerve block, that'll numb the buccal tissue that's next to the mandibular molars only. And this injection site is on the mucous membrane to the distal and toward the buccal of the last mandibular molar tooth in the arch. So exactly where that X marks the spot, that'll numb all those three teeth there. If we were talking about numbing the entire quadrant, we want to do something called a lingual nerve block. This is done so if the patient opens as big as they can. I know that X is kind of placed right there in the middle. It's more to the right, right where if they're open as big as they can, it's right where their condyle meets their jaw, right in the back. So usually I'll have the patient open as big as they can, and I'll put my thumb in the back of their mouth all the way until it touches right where that curvature is. And then right above that is where that lingual nerve block will go. That lingual nerve block will deaden that entire quadrant. So it'll get half their tongue numb, it'll get half their lip numb, and also all the teeth highlighted in red. So let's say the doctor doesn't need to do all of the anterior teeth. If they go a little bit lower, they capture that inferior alveolar nerve block, which is highlighted in green. That for the most part deadens all of those teeth there, except maybe that central incisor. So if we're working on some posterior teeth, that inferior alveolar nerve block is what's going to be most popular for most dentists. It's a little bit easier to get to, and it numbs enough teeth for the most part. The last nerve block that we'll talk about is that mental nerve block. Those of you who are in Den 160, when we talked about landmarks, if you remember where that mental foramen is, that's exactly where we want that anesthetic to go into, right inside that mental foramen, or that hole on our lower jaw in this area here. So the injection will go in that area, and it will, let me see, that one deadens the mandibular premolars, the canines, and the facial tissues adjacent to these teeth. All right. Which injection will affect the hard palate and soft tissues covering the hard palate from the distal of the canines and all the teeth posteriorly? Let's see. Any volunteers? I'm going to pick on somebody. Cassandra? Which injection site was this?
Was it the one that was in red?
Yes.
The lingual nerve block?
Close. This is the greater palatine nerve block. So remember, it's I'll go back. They were talking about the maxillary. So that greater palatine nerve block.
Yeah. Okay.
Yeah, but you had the right idea though. So the mandibular, it would be the lingual nerve block that numbs all of these teeth. So good job. All right, moving on. So here we're talking about, or we're looking at the setup for numbing or local anesthetic. This includes, first you're gonna need the patient's health history. That's what you see in the back there, first and foremost, right? Because if they have some type of heart condition or anything where they're gonna freak out with local anesthetics, we're gonna wanna make sure that we know that because there's different anesthetics that need to be used for different scenarios. We're also going to want to use some topical anesthetics. So on the right hand side, you'll also see a little Q-tip, and it looks like they have some topical cream there. We also want to have the two different size needles that the doctors will primarily use. So we have a blue needle, that's your short needle. And then we have the yellow needle or the longer needle. The longer yellow needle is primarily used for blocks on the mandibular arch. There's two different types of anesthetics there. That one in red is your lidocaine. And the one with the little tan ring onto the left of that, that's usually carbocaine. Okay, we also have our aspirating syringe right to the left of that. A few pieces of gauze, and then to the left of that is our basic setup. Okay, talking about the aspirating syringe and all of its parts. So there's various types of syringes that may be used in dental procedures. The most common is the aspirating syringe. And the aspirating syringe allows an operator to verify that they have not penetrated a blood vessel, right? Because once they penetrate a blood vessel, anesthetic gets into the bloodstream and can create a toxic shock. So the harpoon of the syringe is usually retracted. And if blood appears inside of that glass cartridge, or if blood gets drawn back out, then they know that they have to reposition that needle. Because if blood does get drawn back into the glass syringe, then they know that they penetrated a blood vessel and they got to get out of there before they pump any anesthetic inside. So the parts of the anesthetic syringe, to the very right, we'll see the thumb ring. And then we have the finger gripper, which is that fat chrome piece in the middle. The syringe barrel is that whole long piece. The entire thing is a syringe barrel, or where the cartridge sits inside of. The plunger is that long skinny piece that's inside of the barrel. And then we have the harpoon, and the harpoon is a spiky part that's right at the tip of the plunger. That's what grabs onto the plunger on the inside of the cartridge. And then we have our threaded end of the syringe on to the left end of that syringe. And that's where, of course, your needle gets screwed into. The components of a needle. First, we have different sizes here. That short or 1-inch needle is to the right. That's the blue needle. Again, that's used for infiltration and field blocks and or periodontal ligament injections. That long needle, which is the yellow needle, is 1 5/8 of an inch long. Again, that's used for nerve blocks, whether they're maxillary or mandibular, and it reaches to the posterior area or areas that require penetration of thicker tissue. Usually for the mandibular arch, most doctors like to use that yellow longer needle. And then if we're working with any teeth on top, almost always it's going to be that blue shorter needle. All right, so needle care and handling. You want to make sure that you're only using that particular needle for up to a maximum of 4 penetrations. Anything over that, you want to go ahead and just switch that needle out for that doctor. A lot of times they won't even ask you to. What can happen, or the danger of why we want to change that needle after 4 penetrations is these needles are really thin, and after a while we can get metal fatigue inside the needle, and sometimes these needles can break off inside of the patient. If you can imagine, that's not a very good thing to happen. In fact, that's a very dangerous thing to happen. So if you notice that your doctor has already gone about 3 injections into that, go ahead and just pull out a needle. When they see you pulling out that needle, they'll know why, and they'll go ahead and let you change it out really quick. Also use stick protection devices such as caps and shields. If you've worked with the anesthetic syringe in lab, those are those cardboard shields that are placed on the tip of the needle. Also, you want to adhere to proper disposal. So as soon as we dismiss a patient and it's time to go back to our room to flip it or clean it, we want to make sure we disengage that needle and throw it into the sharps container per OSHA guidelines immediately. Don't wait until that needle gets to the back sterilization area, because that's usually where needle sticks occur when people are quickly trying to sterilize instruments. So to avoid that scenario happening, if we unload that needle in the operatory before that tray even reaches the sterilization area, those are safer techniques. If you do have a procedure stick or something happens where you end up sticking yourself with a dirty needle, the first thing you want to do is immediately squeeze your finger or wherever that needle penetrated you, and you want to get at that area to bleed. One of the reasons for that is if that patient that you stuck a dirty needle with, or if you stuck yourself with a dirty needle that was used on a patient that had some type of bloodborne pathogen, if we quickly squeeze that blood out, it's possible to get a lot of those pathogens or those whatever that patient has out of your body before it gets into your bloodstream. After that, immediately go to the nearest sink and wash your hands as good as possible. I mean, really scrub like your life depended on it. And then you want to notify that dentist right away. Check to see where that needle came from. You want to find out what patient that needle was used on, and then you want to check their medical history. You want to look for things like HIV, AIDS, hepatitis C or B, or any of the bloodborne pathogens that we talked about. And then hopefully they don't. But as always, you want to follow OSHA protocol. And a lot of times, whenever a procedure stick happens, your dentist may send you to the next or nearest urgent care to do what's called a prophylaxis treatment, where they actually give you HIV meds and all kinds of things as a precaution, just in case the patient did have something. It's kind of scary, but there are procedures to make sure, for one, that this doesn't happen, and if it does happen, it's not like it's the end of your life. But yeah, avoid that at all costs. All right, so this is anesthetic cartridge, and just a few components with the anesthetic cartridge. To the right, you'll see that that little rubber piece, or that little tan rubber piece. This is the rubber stopper or plunger. The aluminum cap at the end holds in the diaphragm. And the diaphragm is what the needle pokes into the cartridge, so that the anesthetic can be drawn into the patient. So when you prepare an anesthetic syringe, you want to first select the correct needle that you're going to be using, and this is mostly going to be from your doctor's preferences. Go ahead and remove the sterilized syringe from the packet, and then fully retract the piston rod. So you want to pull on that anesthetic syringe so it's fully retracted, and then place the cartridge into the syringe. Okay, then you want to engage the harpoon. And by that, you'll have the syringe, and then pretend this is the little ring, the little thumb ring. You just want to very carefully but forcefully just tap it with your palm. Whoa. And then, but also when you do that, you want to make sure you don't hold the anesthetic syringe so that your hand is around the glass cap or around the glass part, because if you're too forceful with it, you can actually pop that glass cap, and then you can cut yourself with shards of glass. So hold the anesthetic syringe right around that the fat part, or right below where the glass part is, and then just gently give it a couple taps with your palm. After you engage the harpoon, you want to remove the protective cap from the syringe and then secure the needle onto the hub. And then holding upright, expel a few drops to ensure that the syringe is functioning properly. You want to make sure that you didn't accidentally bend the needle when you inserted it into the cartridge. And if that happened, then when you went to expel a few drops, you wouldn't be able to expel a few drops. And then you would know that you need to change the needle out. And then once you verify that everything is functioning properly, you can go ahead and replace the protective cap over the needle. So that's that patient, that person that's holding onto the syringe. You see that little fat part right above their thumb? That's where you want to hold onto the syringe when you're engaging that harpoon. Don't ever grab or that glass part of the cartridges, because that could be dangerous. And then, so that person was retracting the harpoon because they're about to load it. So once they retract the harpoon, then they can load their cartridge. Usually you want to load it so that the rubber stopper is loaded first. And then holding it like how that person is holding there, go ahead and engage the harpoon by giving it a couple of taps with your palm. And then you want to place the needle into the syringe. You want to do this carefully, and you want to do it, you want to insert the needle straight on, not at an angle. Because if you do it at an angle and then you go ahead and try to thread the needle in, that's usually where I found this usually where I found was when you can bend the needle, and then it doesn't hurt anything. It just, you won't be able to get any anesthetic into the patient. So passing the syringe, after drying the inside tissue with gauze and putting topical into the patient, or wherever the doctor is going to be injecting, you want to pass the syringe over the patient or behind the patient, usually under their chin so that they don't see it if you're going to be passing it in front of them. When you disassemble the syringe, you want to first retract the piston, which releases the harpoon from the cartridge, and remove the cartridge from the syringe. And then of course, the needle after that. So what do you do in the event of a needle stick? Let's see, I see Speranza. Let's see. Can you tell me what we do in the event of a needle stick? Anybody?
You actually don't you apply pressure? Try to get it to bleed out.
Mm-hmm.
To get those pathogens, most of the pathogens out, and then head to a nearby sink and wash it off.
Yeah, I'm sorry, it's because I'm driving. I'm on my phone and my laptop.
You're driving, okay. We'll
Yeah,
drive
I'm sorry,
carefully.
as long as I'm attending, right, Mike? I mean, I'm here. That's all that matters.
That's all that matters, yeah. I didn't know you were driving, sorry.
I'm sorry, I know. So I wouldn't wash it right away, and especially if it cuts, with soap and water. And yeah, I guess just like get a band, wrap it up, clean it out, make sure it's cleaned out properly, and have it wrapped after. Or
Yeah, so that's the second step. And then as Celise was,
Oh.
was telling us too, that we want to squeeze that blood out. If it does get to the point of where it bleeds, go ahead and squeeze out as much blood as you can out of your finger, and then go ahead and wash your hands after that as best you can. So
Okay.
cool. So after that, notify the dentist and determine the patient that the instrument was used on, because you want to review that patient's medical history to see if they have any type of bloodborne pathogens, and then follow the CDC and OSHA protocols. So if your doctor wants to send you to the urgent care to get a prophylaxis treatment, then go get that done. Usually that usually includes testing. So they'll test you for any type of bloodborne pathogens right away. And then usually they'll want you to come back 6 months after that to test again. Just because HIV can sometimes take 3 to 6 months to show up on a test after exposure. So that's going to be important. All right, moving on. So talking about intraosseous anesthesia. What does intraosseous mean? Intraosseous anesthesia means it's injected directly into the cancellous bone. So to do this, you can't just use a regular aspirating syringe. You actually have to use a special equipment. This will numb the lips and the tongue. Actually, it will not numb the lips and the tongue, but everything else, including bone, soft tissue, the roots of the teeth, and the teeth completely are all numbed. So everything but the lips and the tongue are numb with the intraosseous anesthesia. Again, that's where anesthetic is delivered directly inside the bone. Usually that's reserved for like oral surgery procedures. Periodontal ligament injections are used for pulpal anesthesia of 1 or 2 teeth in a quadrant. What pulpal anesthesia means is only the nerve of the tooth is numb, so not the surrounding tissues. And this may be adjunct to another injection where patients are partially anesthetized. Okay, and we also use this when we're trying to diagnose abscess teeth. So if we did a periodontal ligament injection and it effectively gave pulpal anesthesia to whatever teeth that were in question, and those teeth were numb, then we know that it's probably not an abscess tooth. That's probably something around the gingiva that's causing patients pain. Okay, and this is what a periodontal ligament injection system looks like. This was developed in 1905, and the technique is becoming popular again today. It was often used with other types of injections, so not just by itself, but in conjunction with different types, especially when patients have trouble getting numb in whatever area we're working on. And the outcome is pulpal anesthesia, where the entire pulp or the nerve of the tooth gets numb. And this is inserted into the gingival sulcus of the tooth. So right around where you normally the floss would normally go whenever you floss your teeth, a needle would go right into that area and numb that area. So with intrapulpal injections, these are kind of interesting. These are delivered directly into the nerve chamber of the tooth. So these are usually done in root canal procedures or where we have severe abscesses. And I just want to talk a little bit about abscesses and infections. Infections by nature are very acidic. Okay, and the anesthetics that we use are base, so they're very basic. So if we've ever taken like a general chemistry course or any type of science course, we know that bases will cancel out acids and vice versa. So what happens when we have a tooth that's severely infected, we have an infection that's very acidic, and the acid actually cancels out the anesthetic because the anesthetic is basic. And so that renders that anesthetic useless, basically. It doesn't usually work when people have severe infections. Okay, so this is where the horror stories from root canals usually come from. Because in order to give a patient an intrapulpal injection, what usually needs to happen is the doctor needs to drill into the patient's tooth until they hit the nerve chamber. And usually if a patient has a severe abscess, even if we numb them all over the place, they're probably still going to feel the doctor drilling into their tooth. So once the doctor gets to the nerve chamber, they'll get that anesthetic syringe, and they'll literally just inject anesthetic into that nerve tissue until the nerve tissue explodes. So this is very, very painful. But the good thing is it's only painful for a couple of seconds, for literally 2 seconds until we get that pulpal chamber to kind of burst. After that happens, that patient feels no more pain after that. And so these intrapulpal injections are very important because they are almost 100% effective. But if we have to do them, that means that your patient's going to be in quite a bit of pain for just a little bit. Okay, talking about electronic anesthesia. We don't use electronic anesthesia in most offices. If you happen to work in an office that's very updated or bougie, for a lack of better terms, they might have some type of electronic anesthesia. If used with nitrous oxide, it provides a better effect. So it doesn't always work by itself. But it's used when placing restorations or for muscle relaxation or determining the patient's centric occlusion, which just basically means how they bite together on their back teeth. So that's just a little bit with electronic anesthesia. Computer-controlled local anesthesia is something very similar. There's actually a picture of the machine that's used for that in your book. I just want to see what page it's on really quick. Here it is. On page 462 on the bottom of the book, it almost looks like a Cavitron unit. That's just a device that where a microprocessor is used to deliver controlled pressure and volume of the anesthetics at a site. So the microprocessor will actually adjust to the resistance of the tissues, and it's able to deliver a pain-free injection that way. So I've never actually worked in a place that had a computer-controlled local anesthesia system, but it would be pretty cool to see one in use. So this is what a typical nitrous oxide cart looks like. Nitrous oxide is a safe and stable non-flammable gas. Some states allow dental assistants to perform this task under the dentist supervision. Our state of Arizona is one of them, so you will be doing this at some point in your career. Other states only allow dentists or hygienists to do this. But this is when patients who patients who can benefit from the use of nitrous oxide usually have a fear of dental procedures, or they're really sensitive, or they have sensitive gag reflexes. And to ensure patient safety, the health history should be kept current, and the dental assistant should closely monitor the heart rate, the blood pressure, the respiratory rate, and the responsiveness of the patient during treatment. Okay, so this means never leaving the patient alone while they're under nitrous oxide. Not only that, but you should be watching their respiration rate. This is by watching the rise and fall of their chest. And then also the responsiveness of the patient. So every couple of minutes, talk to the patient, make sure that they respond back to you. They may be a little drowsy, and their voice may be a little deep and sound a little funny, but you just want to make sure that they're always responding to you. Asking the patient how they're feeling is key to adjusting the flow for that specific patient. So some patients need a little bit more nitrous, and some patients need less. So I usually ask the patient to tell me whatever they feel comfortable. And you can usually do this by asking the patient, okay, if you feel like you're not feeling anything and you're still a little anxious, let me know, and I can raise the level a little bit. Or if you're feeling like you're freaking out, or if you're losing control, let me know, and I'll bring you back down. And so that's usually how you can gauge how much they need and then adjust it accordingly. Let's see. So the nitrous oxide was first discovered by a guy called Joseph Priestley in the early 1700s. He thought that the gas would cure diseases, which in fact it doesn't. But Horace Wells, a Connecticut dentist, was the first to use nitrous oxide as an anesthetic during a dental surgery in the early 1800s. So nitrous oxide has been around for quite a while and it's still used, very much used today for a lot of different procedures. Okay, they can't be used for everybody though. So some contraindications are patients that have a blocked nasal passage. This is because mask that's used for nitrous oxide only covers the nose. And in order for it to be effective, the patient has to be able to breathe in and out freely through their nose. Also, if your patient is emotionally unstable or if they're drug users, sometimes nitrous oxide can give them a bad trip. And that can be counter effective to what you want. It won't make them less anxious. It might actually make them more anxious. Also, patients during their first trimester of pregnancy, this is when babies do most of their growing. Most of the important development is usually during the first trimester. So if that's the case, we usually want to schedule that patient out until the baby's born. Also, patients that are at risk of bone marrow suppression should not use nitrous oxide, or patients undergoing in vitro fertilization procedures, or anybody else with any type of neurological complaints. So why might nitrous oxide be used for dental treatment? Who could tell me?
To get their teeth pulled out? Or
Yeah, definitely. But sometimes that can cause things like anxiety or which can make it almost impossible to get that tooth pulled out if they're really anxious. So it's used mostly for that, for reducing anxiety and providing relaxation for patients that are undergoing dental procedures, which can be pretty scary for some people. That is it. So that's all I have for chapter 20. Did anybody have any questions at all with this chapter or with any of the other things that are going on? All right, so there's no questions. I just want to go over what's due for tonight. Let's see, you want to, there's the vocabulary for week 4 that's due before midnight. So all of these assignments that are here are due before midnight tonight. So we have the vocabulary for week 4, we have the dentition quiz for week 4, and then the test for chapter 15. And then also you want to read chapter 20 and do the quick checks and the quiz. There's also a couple of anesthetic videos to watch. One of them is an Ed puzzle video. So there's some things that you have to do there that's due by midnight tonight. Study for the chapter 20 tests. Again, those quick checks and the quiz should help you with the studying. And then also don't forget to work on your portfolio project that's due on the 16th, which is also the same day as finals. And then the field guide, the study guide for the final is also due tomorrow. So any questions on any of that? All right. Well, that's it. That's all I have for you for today, you guys. So thanks for joining. I'll talk to you guys tomorrow. We're going to be meeting tomorrow again around this time. So everybody have a good night and I'll see you tomorrow.
Bye.
Bye.